Welcome everybody to our COVID-19 pandemic planning webinar for April the 8th, 2020. I'm pleased to be joined by a number of colleagues today to talk to you about the ongoing efforts at our organization to address the situation that we find ourselves facing with COVID-19. My name's Aaron Levo. I'm the Vice President of Communications and Public Affairs, and I'll be hosting today's webinar as usual. These recordings are distributed and placed on the hub for you to listen to and circulate to others who you think would benefit from the information. So let me introduce who's with me today. Today I'm joined by Rob McIsaac, our President and Chief Executive Officer, as well Dr. Dominic Mertz, our Medical Director of Infection Prevention and Control, Susan Fucciarelli, the Director of Health, Safety and Wellness, Andrea Frolick, our Director of Clinical and Organizational Ethics, and Dr. Michael Stacey, our Executive Vice President, Academic and Chief Medical Executive. Thank you all for being a part of the discussion today. Rob, I'm going to go to you first. Could you give us an update on what's really topical this week, our current state, and what's just around the corner?
Sure. Thanks, Aaron, and thanks everyone for joining us today. So this week, we've been speaking about our plans to manage the anticipated surge at HHS, both internally to our staff and externally to the media and to our community. We've created a lot of capacity in our system for a surge of patients, and we're planning for options that will allow us to create even more capacity as we begin to see more COVID patients arriving in our hospital. That said, no doubt the most powerful plan to mitigate the impact of the virus will be the willingness of our community and our workforce to physically distance and practice infection control measures to the greatest extent possible. In terms of news this week, I'd like to take a moment to acknowledge the incredible work by many at HHS and partners across the city who've come together to launch a new strategy to support long-term care patients in their homes using virtual care. This model, developed at HHS in partnership with St. Joe's, will enable long-term care providers to gain access to emergency physicians and alternate care pathways for residents of nursing homes who are in need of advice and care. This should help to reduce emergency department visits from nursing homes. This is really innovative work that will help folks in long-term care while protecting hospital capacity. And I know people worked super hard to develop this model, and it's extraordinary that they were able to launch it in such short order. Also this week, our ethics team launched a suite of tools to support resilience among our staff and physicians. Burnout in healthcare is always a concern, but that is even more so in the context of a crisis. So these strategies, which are being shared, will help us to take care of ourselves and each other, allowing us to be available and present in the moment as we ride out this pandemic together. Andrea Frolick is going to speak to the resilience plan in more detail. And finally, maybe I'll just touch on some news around ethics and goals for care. You know, talking to patients and families about their goals is always important, but more important now than ever. We've launched a toolkit to support providers, healthcare providers, in having these difficult conversations about goals of care with their patients. Beyond that, HHS has also demonstrated provincial leadership in creating a protocol to guide healthcare providers in the unfortunate event that we are overwhelmed with patients. These are weighty, difficult decisions that I hope none of us is forced into in the coming weeks and months. But if we do have to go through such an awful eventuality, these resources will guide us through these very challenging scenarios where we're having to allocate resources that are insufficient for all of the patients that we're trying to take care of. Dr. Stacy is going to speak to that shortly. So I think that's it for now, and back to you, Aaron.
Thanks a lot, Rob. Next, Dr. Dominic Mertz, I want to go to you. I'd like to ask a bit about what trends we're seeing locally in terms of the pandemic. Can you speak about where we're at and what we can expect over the next 2 weeks in terms of the spread of the pandemic locally and in the province?
Yeah, thanks, Aaron. So on this slide, you see that we are currently at, as per today, 198 confirmed positive cases. I think much more interesting than the numbers you see here is looking at the trend. I will get to that on the next slide. Just the other numbers are very similar to what I showed you the last time. Roughly 15% of the cases are hospitalized. We have 5 deaths so far in Hamilton, and 5% were long-term care facility residents. Only 40% have resolved at this point, but keep in mind that resolution means in an outpatient at least 14 days after onset of symptoms, and in an inpatient we actually swab them repeatedly to consider them cleared. This gives you more of an idea of how our curve looks like by week, and you also see that the blue line up there, that's influenza. So compared to influenza, we still have very small numbers of COVID-19, and it looks like a pretty flat curve so far. Always be careful about the last point in a time series. This will change, the second last probably as well, because there may be cases that are attributed back to the last week because that's when onset of symptoms was. But it's pretty stable over the last few days. We have maybe 10 to 15 cases per day, new cases per day in Hamilton. This gives you a bigger picture across Canada. You see that Quebec has the highest numbers with more than 9,000 cases, followed by Ontario with more than 5,000 cases. Interestingly, BC, who started off with the first cases and then was or had higher numbers for a long period of time than us, has a much flatter curve than Ontario has. And again, the key here is how many new cases do we see each day, and that's what you see here. And the last 24 hours had the highest increase so far with roughly 500 cases. We were usually in the range of 300 to 400. So Ontario-wide, it looks like the number of new cases per day continue to trend to increase, while in Hamilton we are in a better position with the number of new cases per day are pretty stable over the last week or two.
Well, thank you for that update. It's still so critical that we maintain our stance on social distancing. I know it's impacting people in so many ways, and all of this preparedness is definitely influencing the questions that are coming through at the staff email line, talking about how are we going to maintain the pace moving forward in terms of the workload and the planning that we're undertaking. Andrew Frolick, I wonder if I can go to you now and ask a little bit about resiliency. As Rob mentioned earlier, there's some exceptional work rolling out right now. Like how can we cultivate resiliency in our workforce during this incredibly challenging time and meet the demand that we see ahead of us?
Thanks, Aaron. Well, we know how challenging healthcare work is in normal times. We are constantly confronted with loss and grief and trauma and death on a regular basis. That is the nature of patient care in acute care. And we are an intrinsically resilient workforce. But as you've said, the pandemic challenges our resilience in new ways. We may feel fearful for our own safety and the safety of our family and friends, our colleagues and our patients. And as Rob and Dominic have mentioned, we are facing a surge of potentially unprecedented volumes of acutely ill patients. And many of us are struggling to navigate new moral dilemmas every day. So our job as a healthcare system is to save as many lives as possible in a pandemic situation. And we can achieve that together if we fuel our resilience both individually and collectively. So we've created a suite of resources and tools to support this. But let me step back and talk a bit about what resilience is. So it is our ability to adapt to adversity and our capacity to persevere in the face of challenges. It's actually an internal growth process. And most of you have heard of post-traumatic stress disorder or PTSD, but what probably most of you don't know is people who experience trauma, only a very small minority of them actually experience PTSD. The vast majority, over 85% of people who experience trauma experience something called post-traumatic growth. And post-traumatic growth is possible when we make a conscious choice to cope and to make meaning of our difficult circumstance and to remain hopeful. But this requires a regular daily practice of fueling the fire of resilience. And I love the metaphor of a fire of resilience because just like fire, it's catching, and it also is something that other people can warm themselves to. So just like cynicism or hopelessness can be catching or contagious to the people around us, so can resilience and hope. So we've created at HHS a pandemic resilience support strategy, which is a comprehensive suite of tools and resources and services grounded in neuroscience and best practices related to trauma-informed care that are designed to promote the resilience of everyone across the organization, staff and physicians and leaders, as we respond to this pandemic. And this graphic shows that there are sort of multiple concentric circles that will support individuals, that will support teams on the ground, and that will support our whole organization through the Ethics and Resilience Task Force that has been created and that reports to the command center. And I really want to acknowledge the incredible creativity and expertise of our Resilience Support Working Group, which includes our own experts, social workers, psychologists, psychiatrists, mental health educators, spiritual care providers, who've conceptualized and designed and launched the strategy in only 4 weeks. So what we are in the process of deploying now is a whole suite of services and resources. The practical framework of this whole resilience strategy that is based in the neuroscience of stress and resilience is called PRN. As most of you know, it means as needed. And it's appropriate because we need to be dosing ourselves with resilience enhancing practices throughout our days, and not just after we leave work. It's something we should be doing on an ongoing basis in the flow of work. So PRN starts out with the practice of pausing. So why don't we practice this together now? So I invite any of you listening to just notice and pause. How am I feeling now in this moment? What is my stress level? Am I in the red zone? Do I feel frantic or numb? Am I in the green zone? Am I feeling in flow or energized and focused? Or am I somewhere in the middle? So simply acknowledging and pausing how I am in the moment. That's the P of pause. And then R stands for reset. And one of the best ways to reset our nervous system and calm our stress response is by taking conscious breaths. So take a moment to take 3 to 5 conscious breaths. Just spending a minute feeling that nourishment and refreshment of your in-breath and a kind of letting go and release of the out-breath. And perhaps as you breathe out, you can notice if there are places in your body that feel tension, and invite that tension to melt as you breathe out. And then the N stands for nourish, and there are many ways to nourish ourselves throughout our days. We can think about something we're grateful for. There's always something to be grateful for in every moment of every day. Or we can turn our minds towards someone who supports us, someone we can connect with to encourage us in the middle of a tough day. I like to think about the fact that none of us are in this alone. Whenever I get discouraged, I remind myself that there are literally hundreds of thousands of healthcare workers all over the world confronting exactly the challenges of COVID that we're facing now. We are connected to a global community of COVID warriors, all working together to save lives in New York City, in Tokyo, in Italy. And I know when I feel overwhelmed, this gives me courage and it feeds my own fire of resilience. So we're going to talk in a moment about this resilience toolkit, but there are other processes and services coming online, including to the right there, a resilience support team, which will be psychosocial support on the ground in our highest trauma and busy units, including on COVID units, ICUs, and in the EDs, and that will be launching in the next couple of weeks. We're launching a COPE line, which will be a 24/7 peer support line available to all staff and physicians. We have leadership support already available, our organizational development coaches who support and offer strategies to leaders. And very soon we'll also have physician-specific resilience strategies through physician peer support. So yesterday we launched our resilience toolkit. It's designed for individuals and teams to really integrate these short and concise practices to boost and fuel our flame of resilience throughout the day. It's available on the hub now. It includes some easy ways to monitor our own stress level, to integrate these short practices that can be done in any moment of the day. It has multiple formats on paper and web-based and videos. And these are very easy to integrate into your own workflow and into your teamwork, including CQI huddles or debriefings or meetings or handovers. So we'll be giving you some tips and tools around how to integrate these neuroscientifically proven strategies to support resilience in the coming days and weeks. So I want to close this by reminding us that our resilience is catching when we fuel our own fire. It allows us to be positively contagious to the people around us and encourage one another to be vectors of care. And I want to close by sharing with you this beautiful quote by Paul Williams. When you go out and see the empty streets, the empty stadiums, the empty train platforms, don't say to yourself, it looks like the end of the world. What you're seeing is love in action. What you're seeing in that negative space is how much we do care for each other, for our grandparents, for our immune-compromised brothers and sisters, for people we will never meet. People may lose their jobs over this. Some may lose their businesses, and some may lose their lives. All the more reason to take a moment when you're out on your walk or on your way to work or just watching the news to look into the emptiness and marvel at all that love. Let it fill you and sustain you. It isn't the end of the world. It is the most remarkable act of global solidarity that we may ever witness. So I thank each of you for the love and solidarity you're showing to our community, for those who are physically distancing and working at home, and for those on the front lines who have stepped forward with courage and creativity in the face of the challenge of responding to the coming surge of patients. Keep fueling your fire of resilience. Your flame can light the way for your patients, your coworkers, and your own friends and family. Thank you and stay strong.
Thanks very much for that, Andrea. And we'll continue to bring updates about this important work. Absolutely critical that we each take a moment to reflect on the impact on ourselves and understand how we can maintain our resilience in the face of what we are preparing to do and doing already together. It is for sure a marathon and not a sprint. So powerful messages and important tools for everyone. I want to go now to Dr. Michael Stacey. One of the themes or questions that's arising a lot, and it is for sure a challenging one, is around understanding our patients' goals. You know, as people think about what matters to them during the pandemic, goals of care are really important, and maybe now more so than ever. So how is this practice of understanding what our patients' goals are being maintained during the pandemic? Can you talk a bit about that?
Yes, certainly, Aaron, and thank you. I think it's always important for us to think about our health preferences before we get into a crisis situation, but particularly in this current situation, it is important that we do make sure that our medical teams are aware of our health preferences particularly so that we don't receive care that may not be wanted or even beneficial for us. I think in these times of pandemic, the additional issue for us is that we may at times not be able to provide the treatment, even if it does align with your preferences, simply because we do not have the resources to do that. I mean, we're ever hopeful we won't get to that point, but it is possible we could. And to that effect, the team within ethics and other parts of the organisation have developed some toolkits, or a toolkit rather, with a number of elements to it to help you with this process. There is a introductory page with a video and a flow map, and there are a number of information sheets and conversation guides. And the conversation guides are particularly to help to have those conversations in the light of the fact that we may not be able to offer the treatment that a person might otherwise choose to have. And this will apply both to COVID and non-COVID patients, because clearly both will be impacted by this supply, even though they may not have the same underlying medical condition. And then there are other parts of that toolkit which provide letters to help to explain to the patients and their families why a particular decision has had to be made, and then also the post-order set so that we can document this within medical record. You can find these in the ethics area on the hub, and there is also in-person support available. That shows us really a flow chart, if you like, just walking through the various elements of having those conversations with both COVID and non-COVID patients, and then documenting those within the patient record. So an important thing to consider at this stage, and the team is here to support you for having those, what are very difficult conversations.
Another question I'd like to pose to you that came in through our staff email line, and for sure mirrors some other questions that we've received. As we start to think about the availability of resources, we, I think, read the media. The question is, how are decisions being made about the allocation of critical care resources? If we get to the point where demand outweighs supply, what are we going to do?
Yes, and I think that is a situation I think we would all hope we don't get to, but we are aware from experiences in other countries, particularly with this COVID-19 pandemic, that those difficult decisions have had to be made. And so there has been a team comprised of ethics and other parts of the organisation that have helped to develop a critical care triage and resource allocation protocol. And the point of this protocol and the tools that it has within it, it's really about ensuring that we triage who receives care so that we can save the most lives possible by providing the critical care to those most likely to survive. And I think the other particular thing to note from it is that in this process and in the tools that are within this protocol, the decisions are made really on an individualized manner, regarding each patient. So they're taking into consideration that particular patient's underlying health conditions and predict whether they will recover from a critical illness and from the extent of treatments that would be required. So the tool is a support for the clinicians to make these decisions. The clinicians will have a tool to fill out, but they won't be alone in making the decision, because there will be a triage team that will be there, and each of these decisions will go to that triage team if we do have to come to a point of not offering care to some patients. So a lot of supports have been put in place to help make these what would be very difficult decisions.
And can you expand a little bit? How were these protocols developed? Who was involved? How did we get to this? How were these established?
Yes, and thanks, Aaron, for that. I mean, we've had a very diligent team within the organisation. There has been a task force as part of the command centre that's looking at both the ethics and the resilience elements, of this work. And within that team, we've had people from our ethics team, including Andrea, who you heard from earlier, but people from intensive care, from medicine and emergency. And it's important to know too that many of these members participated in a provincial working group that developed the provincial guidelines, and the guidelines or the protocols are all in alignment. So a lot of very good work by some very talented people within our organisation.
Good stuff. Thank you very much for that, Michael. Very important content to talk about today. I want to go next to Susan Fucciarelli. Susan, one of the things that we want to talk about that's coming up on our staff email line is about work, and you know, the flexibility and availability of our staff is super important right now to being able to meet the demands that are being placed on our organization to get through this tough time. But it also matters, you know, to our staff, like what should they do if they don't feel safe about the work that they're doing? What happens in those instances? Can you talk a bit about that?
Sure. Thanks very much, Aaron. You know, and it's completely understandable that our people are concerned. These are really unprecedented times, and we have a lot of new risks that are associated with COVID-19. You know, I really do want to assure everyone that we are continuing to address the safety risks that are associated with our people and associated with COVID. We've got a dedicated team of subject matter experts, as Dr. Stacey has just indicated, people from all different walks of clinical expertise, infection control, ethics, health and safety specialists, and all of these individuals who are coming together to provide recommendations based on scientific and other available evidence. Fundamentally, one of the principles for this group that is driving our recommendations is to keep our healthcare workers safe. Our processes are focused on ensuring the safety of our staff and physicians so that they can continue to deliver the care to our patients. But, you know, we do understand that there are going to be situations where people might not feel safe. So if anyone feels that the work that they are doing poses a health or safety risk, they need to discuss this first and foremost with their leader to try and resolve it together. Nobody knows that work better than the individual who's doing it, and the leader really plays a critical role in helping to address what those concerns might be. But if it goes beyond that and somebody continues to have concerns, it doesn't get resolved at that level, then we already have an existing protocol to address this. So it's not anything new that we've had to develop because of COVID-19. If needed, we would then move through what we call the work refusal process. It's a very formal process that starts again with the leader, but then it progressively involves other people such as the Joint Health and Safety Committee, the worker member, and ultimately, if we still can't resolve it at that level, it would move to an external body, being the Ministry of Labor. So a Ministry of Labor inspector would then come in as an impartial third party. They would listen to all of the different elements that are involved in what is being asked of that worker to do that work, and whether or not we do have the appropriate safety mechanisms in place. Ultimately, it would be the ministry then, at the end of that process, that would determine whether or not that work was safe to continue with. I just want to point out that because this is a legal process that's under the Occupational Health and Safety Act, there are very specific rules that have to be followed when we go through this process. One of them being that an individual needs to be at work and needs to be refusing work that they're actually being assigned to do, not something that's in the future that they may be asked to do at another point in time. So that's just an important part of this. Details of the process itself are available on the hub in the Health, Safety, and Wellness section. And of course, because it is a formalized protocol, it's in the policy library as well. So I hope that people will be able to look to those resources if they are feeling any kind of trepidation about the work that they're doing. But I really do encourage them first to go ahead and speak to their leader to see how best to resolve the situation.
Thanks very much, Susan. One more question for you. Like recognizing that we have individuals who might work at more than one organization and then come to work at Hamilton Health Sciences. So how are we ensuring safety for our workers, recognizing that we might have people in our midst who are working at more than one employer?
Yeah, that's a really great question. And we do recognize that many of our healthcare workers, particularly because of the area that we are in, work for more than one organization. So, for example, we have many that work here at Hamilton Health Sciences as well as at St. Joe's. So I just want to ensure that people understand that we are following the principles from Ontario Health that support this notion of people working at multiple locations. Currently, there are no restrictions preventing individuals from working at more than one organization. However, ensuring that our healthcare workers are safe to continue working at both organizations needs to be a key focus. So following things such as the screening protocols, making sure that you are appropriately adhering to PPE protocols, and all of the other safety measures that are put into place at each of the organizations is very important to follow. In order to protect the safety of our patients and our staff, if somebody does experience an unprotected exposure at one facility, it may then prevent them from working at the other. So that's something, a process that we would work through with that individual. Employee health would be involved in that conversation, and our occupational health physicians. So by limiting that type of transference between the two organizations, if somebody has been unprotected and then has an exposure, it's going to help to further reduce the possibility of spread within our organization. So, simply put, we want to avoid that situation in order to ensure the safety and well-being of our healthcare workers here at HHS, at any of our sister partners, as well as our patients, of course. So we still have some work to do around this. We currently don't have a list of healthcare workers that work for multiple employers. So we're looking at best how to gather that information in the near future in somewhat of an automated way. So we will be able to provide more information about that fairly shortly.
Thanks very much to you, Susan, for joining us today, and thanks for those answers. Conscious of time, we always like to try and keep these broadcasts at about 30 minutes. I'm going to call it there. Thank you, everyone, for joining us, to all the panelists for joining us today. Again, as is our usual practice, this particular broadcast will be posted on the Hub, and we'll continue to bring information to our workforce using this medium, based primarily on questions that we're receiving through the staff email line, staffcovid19@hhs.ca. Please continue to use that line to send us your questions so we can inform the content of future webinar broadcasts. And also, please go to the Hub for information. Download the Hub app to stay on top of the latest that's happening across Hamilton Health Sciences as we face this pandemic together. So until next time, thank you all and stay safe.